I work at Dartmouth-Hitchcock, but I'm also the finance director for Region 1. And so I've worked with several of you in the room on that work. I've been at Dartmouth-Hitchcock for almost 20 years. Previous to that, I worked with Susie Catalona, Phil Wysick at West Central for a couple of years. And before that, I audited banks. I worked for a public accounting firm, and I knew nothing about healthcare. So what I know about alternative payment models, risk contracting, I actually learned on the job while I was at Dartmouth-Hitchcock. So it is possible to learn and make it so it's not rocket science. So if we start with what we're going to do today. So think of me as your travel guide to a different country, and today's presentation is really, consider that you're in Spain or Mexico and you want to know how to ask where the bathroom is. You learn how to say, ¿Dónde estás los baños? You don't learn how to have a really technical conversation necessarily with someone who is very fluent in Spanish on the fly. You need to learn the basic fundamentals. So that's what today is. We may need to come back and have a deeper conversation, maybe risk contracting 201 that talks more about the technical aspects related to contract and their models, but today is really just to lay the foundation. So when we use the same words, when we talk to the MCOs, when we talk with the state, when we talk with each other, we are meaning and saying the same things. And we'll give a little bit of an overview of a very, very simplified risk model and what the state's timeline for development of an APM is. So to remind everyone, as part of the DSRIP grant, the state made a promise to Medicare as part of getting that 1115 waiver that said that by 2020, 50% of Medicaid payments to providers will be in the form of some yet to be defined alternative payment model. The state is in the middle of garnering consensus, feedback, input from providers around the state, so hospitals, community mental health centers, federally qualified health clinics, private practitioners, you name it, they've been asking and convening meetings. There is no real consensus yet on what a model will look like. What I think the providers have tried to say to the state is not one size fits all. What an academic medical center like Dartmouth-Hitchcock versus what a small two-person practice or a psychological counseling service can offer from financial resources, staffing, just the ability to manage some of these models is vastly different and needs to be accounted for. So I think the state has been very interested and willing to listen and try and work with the providers as we come up on this deadline of what it might look like. So at the federal level, CMS had actually created the Learning and Action Network called the LAN, and they put into 4 different categories how they define particular payment models. And in the LAN's mind, and I don't mean land mine like a bomb exploding, but in the mind of the LAN, they are saying that only categories 3 and 4 really count as what they call an advanced alternative payment model. And that's really where they are asking providers to assume financial risk, and it doesn't look like most of our payment systems look like today. But it'll take some time to get there. So I'm going to start with basic revenue terminology and taking what I talk about in finance to what normal non-finance people might say. So when you hear the word charges, you should think sticker price. When you hear gross patient service revenue or gross client service revenue, you should think about that's actually what the revenue is at the charge level or the sticker price level, right? Contractual allowances are really what is the discount off sticker price. So if you're going to buy a car, you don't generally pay the sticker price. You get dealer discounts and a bunch of other stuff that you end up with in healthcare. Net patient service revenue or net client service revenue. It's really the net amount that someone pays for that service. And then the payer mix is really just the conglomeration of all those different types of payment streams that come from a patient or client across an agency, a hospital, a physician practice. Technical versus professional. Technical is really more at the hospital level. Those are things like inpatient services, ancillary services like labs, radiology, imaging tests. The professional services is the stuff most of you in this room who are clinicians do, which is the professional services. These are the services where you meet generally face-to-face with your patients or clients, and you're providing direct patient care. And at Dartmouth-Hitchcock, which is Dartmouth-Hitchcock Clinic across our region, and Mary Hitchcock Memorial Hospital, the vast majority of our net patient service revenue, or that total amount that we get from all the patients we see, is really on the technical side. So it's 65% of our net patient service revenue comes from the technical side. The rest comes from the professional, even though at Dartmouth-Hitchcock, we have over 1,200 professionals working and billing on our behalf who are physicians or associate providers of some sort. So it's really a lopsided model on the hospital side. If you took West Central Services, it's all professional, right? And if you took a physician practice like at New London, it's all professional. But it's just a different way to look at it. So what do we mean by cost? Everyone loves to talk about how much healthcare costs. Well, it depends on who is it that we're talking about, right? So definition one is how much does it cost me to get a service from someone else, right? So that's my cost. That's my deductible. That's my copay. That's the amount that WellSense is adjudicating on the claim for, or how much someone's paying for an insurance premium. But there's a second definition. How much does it cost someone to provide the service that I'm getting? So how much does it cost Alice Peck Day Memorial to actually provide an office visit and an associated lab test if I walk in the door? In the public domain, the cost that everyone is talking about is that first definition. What's it cost to them? Not what does it cost to deliver the service. So if we think about Medicaid in the state legislatures, the state, everyone else is really focused on door number one. But we as the provider community also are vastly aware that Medicaid payments don't actually cover the cost that is required to deliver the care to the patients and clients that we're treating. That's the dilemma that we all are facing as we're working with the Medicaid Department, New Hampshire Health and Human Services, and others to create alternative payment models for the Medicaid program. There's not enough money to go around, and there's not enough money to actually cover the cost of all the great work that everyone's doing. So who pays the bills? So when I say governmental payer, you should hear a Medicaid. You should hear a Medicare. When I say a commercial payer, you should think Anthem, Aetna, Cigna. When I say self-pay, you should think of someone who doesn't actually have insurance. Doesn't mean they can't pay. It means that they may be a self-employed logger, and so they are paying the bill themselves. Charity means people can't afford to pay. Doesn't mean they won't pay if they had the option to. It means they can't pay. And the health insurance exchange marketplace means where someone buys Obamacare. It's the individual marketplace, the ACA, Affordable Care Act, where individuals who don't have insurance through their employer are accessing insurance. So everyone talks about accountable care organizations, or ACOs, centers of excellence, patient-centered medical homes. Those are delivery models. Those are not payment models. They're really just how we're organizing the delivery of care, and we're calling them certain things, but it is not how we're getting paid. This is how we get paid. So we start on, and I'm going to walk through what some of these specific buckets mean, but you start with fee-for-service. That's really where a clinician is billing for the visit that they just had with their patient, and they're getting paid for it. There's no look at, was it a quality of care service? Was that value add? It's really just, I billed a 99213 for an established patient for the 45 minutes I spent with that patient, and I'm getting the payment back from the payer or whoever is on the hook to pay that bill. Then we have pay for reporting, pay for performance, bundled payments, capitation, global budgets. So we'll talk about that. At the end of the day, where everyone is trying to go is at the very, very end. Not everyone's going to get there. It's not possible. Not everyone has the financial wherewithal to actually assume enough financial risk that they could put their practice, their hospital, their agency at such financial risk that they're willing to potentially go under. That's not prudent business practice. So in the first two categories of that LAN model I showed you previously, there's fee-for-service, which I've just described. This is a traditional way everyone gets paid, regardless of whether you're a community mental health center, for the most part, for commercial payers, let's say. Whether you're a hospital, physician practice, this is the world we live in right now. It means I've submitted bills, and we get paid basically for volume, not value. Pay for reporting means I'm still going to get paid on a fee-for-service basis, but someone might be looking at, am I measuring diabetes in a certain measure? Are my patients controlling their blood pressure? I might get a bonus for that if I just report and say, yeah, I'm measuring it and this is what it looks like. Pay for performance means not only am I reporting on that information, but someone's measuring me and saying, you know what, we wanted you to have 90% of your patients within a certain framework. You have 80%, so you're not going to get a bonus, but we're still going to pay you for that visit that you provided the patient. A bundle payment or an episode of care is a fixed payment. So let's take a total hip replacement. So a hospital or a physician practice may agree to accept from a particular payer a fixed amount that would include both the surgery, the pre-admission testing, the post-admission work, and the professional services, the doctor visits associated with that. So let's just say $25,000. It's not the right number, but let's just say that's the amount that a hospital might accept. If something happens and that an individual's specific surgery has complications, they get sepsis, whatever it is, the hospital in general is still only going to get that $25,000, and they and the physicians would absorb anything that was over that $25,000. If through standardization, reduction in variation in care, and other measures, they actually remember costs, what it costs to deliver that care. If the hospital and the physicians together actually provide that service at less than $25,000, let's say $20,000, then that $5,000 difference between the $20,000 and the $25,000 is theirs to keep. And they invest it in their systems or they do whatever they want with it. But that's a really specific, usually condition or procedure focused. Then we go to where CMS and now the state of New Hampshire are trying to move people, which is really more of a risk model. And we use the word upside risk, which sounds like it doesn't make any sense, right? Because upside and risk shouldn't be in the same phrase, right? But it really does mean that you're at risk of not earning the bonus. And all it means is that you're agreeing to manage a patient population, either a full patient population, a subset, and in return for effectively managing to an agreed upon expenditure for that patient population, you might earn a shared savings or upside. And I'm going to talk more about that. Then there's the most risk, which is you're also accepting that if your patients incur more claims cost, because for whatever reason, so that patient population suddenly develops, I don't know, there's a flu epidemic. And suddenly what history would say you spent on that patient population is no longer the actual reality. The provider in a two-sided risk model has agreed that if they and their patients incur more costs than was expected, the provider is on the hook to write a check back to whoever the payer is for some agreed upon difference. That requires a lot of ability to manage and to understand what risk you've just put your organization at. And this is at the very end. So this part of the capitation model is where the CMHCs and the state are. So they've agreed with the state of New Hampshire for the services that are provided within the virtual walls of the community mental health centers. They've accepted some risk. They've agreed we're going to manage these patients or clients who are assigned to us, and within a certain corridor, we're going to be responsible for either the good or the bad, right? But they're not responsible for the services that don't happen within the walls of the community mental health center. That's someone else's responsibility, either the payer or maybe a different provider who's accepted risk for that different type of service mix. Comprehensive capitation or payment models are where a provider assumes what we call total cost of care, where that provider organization has assumed risk to manage a patient population regardless of where they get care and regardless of what kind of care they get. So if we think about a health system might accept a total cost of care for, I'm going to say, an Anthem population. In that Anthem population, that system has accepted general health, both hospital inpatient, hospital outpatient, professional services, maybe drug costs, maybe behavioral health, but probably not. Maybe transplant cases, maybe not. And within that, there's an agreed upon amount that we're working towards and we're trying to manage. And there's also a connection to quality. So what I'm going to show you, I'll show you after. I'll show you a model of, so you can see in sort of an easier to understand way how these models might work. But this last bucket is the most financially risky of any of these models. Done incorrectly can actually implode a health system, a physician practice, a community mental health center, a social service agency who enters into these. So if you think if anyone was in healthcare in the 90s, capitation, managed care, which was not linked to quality, but did cause many physician practices, many hospitals in the country to actually either declare bankruptcy, have significant financial issues. In general, it was a model that works at a certain point if it's done correctly, but if it's done incorrectly, really bad things can happen. We're trying to avoid that, and I think the state's trying to avoid that. The Medicaid offices, the MCOs are trying to avoid that. None of us want to create and design payment models that cause the state's provider network to stop being able to provide needed care to our patients and our families. So lastly, value-based arrangements, that's really just a fancy way of talking about how we're trying to move from getting paid for volume to getting paid for the value that we're delivering our patients and our clients. And at one point, there was the triple aim, which was created in 2009 by the Institute for Health Improvement. And it was really focused on better health, better care, lower cost. And recently, it's been expanded to be the quadruple aim because there's been a recognition that the providers who are involved in this work are burning out. And so there needs to be some appreciation and some recognition and accommodation for our physicians, our clinicians, our nurse practitioners, our nurses, our social workers, that the experience of providing care also is factored into how we deliver care. And in all of these models, payment models are not what should be driving the bus, right? Payment models should follow the delivery of care. That's not always how it happens, but that is the ideal. I should not be the one who says, this is the payment model that we're going to do, and present it to clinicians and the clinical leadership, and then expect that they're going to change delivery of care based on a payment model that we came up with. It should be the other way around, but unfortunately, that's not always the case. All right, so risk contracts, we call them attributed lives or assigned lives or covered lives. It really just means who are the individual patients or clients who have, in general, selected a primary care provider. Could be a doctor, could be a nurse practitioner, could be a physician assistant in some cases. And that's where they're getting their primary care. So most of the models that at least I'm familiar with are based on, they all start with primary care. It centers around primary care and then spins out. The CMHC model is slightly different because it's based on where the Medicaid recipients are actually getting their behavioral health needs and less where their PCP is. And then revenue at risk is really just what's the amount of dollars that an organization receives or has exposed to potential unknowns based on those risk contracts. All right, so this is the oversimplified version of how a risk model works. So we start with shared savings. So the shared savings model, remember, is I earn money if my organization saves on the cost of care. I don't do anything if I've actually overspent, right? So if we start with a cost target. So the cost target in this model is $100. So that means that the providers and the payer have come to some agreement, whether it's using a look back at a historical 2-year period of paid claims or some other mechanism, to say the expected payment, the expected spend for this patient population that I'm on the hook to manage is $100. In reality, my patients, my clients, really only incurred $90. So I have $10 left, $10 less than that target. And in that model, as this, at least in this illustration, I don't get to keep that whole $10. I have to share it with the payer because there's something in it for the payer, there's something in it for the provider, hopefully there's something in it for the patient or the client. So in this model, it's a 50-50 split. I get $5, the payer gets $5. In the shared loss model, we're still going to say it's going to cost $100 expected to spend. But now, my patients, my clients, have actually incurred collectively $110. We've blown through the budget by $10. Again, in this model, I'm not absorbing that full $10. I'm absorbing 5 of it because this is a 50-50 model. So the payer absorbs $5 of that overspend. The provider writes a check back to the payer for that $5. This is the highest level. Anyone who works with these models, if only it was this simple. And that's the problem with many of these models is they're very complex. They're administratively burdensome. They require resources and talent that many of us don't have in-house, which means we engage actuaries, we engage health economists, we engage consultants, because when these numbers get big, we're putting our organization's financial health at risk, which means we need to invest in those outside resources that we don't have the in-house talent for if we're considering these kind of models and figuring out how we manage as effectively as we can to do the right thing for the patient, but to also do the right thing for our organization. So now if we take that and move to where the state's going. So as I said, the state's on a roadmap to get to 2020. And as part of that, we're on that roadmap too. The state has convened several listening or stakeholder sessions, as I mentioned, to learn more about what alternative payment models already exist in the state, because many of the hospitals and physician practices have alternative payment models already on the, with commercial payers or Medicare. The CMHCs have their relationships with the MCOs for Medicaid, and there may be others in the state. And so the state's trying to gain as much knowledge as they can, synthesize hear themes, understand what the challenges, barriers, opportunities, lessons learned, things to consider as the state tries to develop its ideal APMs. Now this gets hung up in another timing issue. In the state of New Hampshire, Medicaid expansion is not a given. Right now, the current Medicaid expansion program expires at midnight on New Year's Eve 2018, if the New Hampshire State Legislature and Governor Sununu do nothing. Now, there are many in the state, including in the legislature and including Governor Sununu, who are interested in trying to figure out what a model for calendar 19 going forward could look like for Medicaid expansion. So right now in the Senate, SB 313 has been introduced and is a model for where at least the Republican senators are thinking they could get on board with Medicaid expansion and other particular healthcare reform initiatives. Now, part of the challenge, in addition to trying to now take what do the providers want, what does the state Medicaid and HHS offices want, okay, now what does the state legislature and what does the governor and the executive council want? And, oh, by the way, the managed Medicaid organizations, their contracts are up. They're currently in a 5-year contract, which ends this year. So there needs to be a rebid, reprocurement process, which is actually referenced in SB 313 of what the models might have to look like from an alternative payment model and other contractual requirements that the Senate is putting forth. Who knows where any of SB 13 is going, what the final version, if any, really looks like. But over the next weeks and months, the state legislature will be debating what's the future of healthcare delivery payment models for at least the Medicaid program and potentially the individual Obamacare market for 2019. So I encourage you all to be involved, if you have others in your organization who are paying attention to this, we really need to be involved, influence as much as we can. The Region 1 Finance Committee, we've reconfigured to actually focus on alternative payment models, so woo, party time. And we'll see. I personally think this is a really tough challenge in front of us, and if it was just Dartmouth-Hitchcock, I'll just wear my DH hat for a sec. If it was just Dartmouth-Hitchcock and WellSense or New Hampshire Healthy Families talking, we could probably figure out a model that each party could collectively live with and we could move forward. But it's not just DH, and it's not just WellSense, and it's not just New Hampshire Healthy Families. There's a really broad constituency who has to be at the negotiation table and provide influence. And then that's to say nothing about the Medicaid beneficiaries, their families, the communities, the social service agencies who are supporting them. So more to come, but this is really something that will impact us all, and the more that we know about it, the better off we'll be. That's it. Questions? Did I make your head spin? Phil?
Lynn, did you say that by 2020, 50% of all the Medicaid expenses have to be under alternative payment, or is it 50% of the providers have to be?
That's an interesting question, because what they committed to was 50% of Medicaid provider payments to providers. Now, what we at our stakeholder meetings have said is we would propose that the 50% actually be counted by 50% of the Medicaid beneficiaries are assigned or attributed to some form of an alternate pay model. So if you take it from a primary care perspective, 50% of the Medicare beneficiaries have a PCP. Those PCPs are in some form of alternative payment model, good to go. Versus counting 50% of the total Medicare spend has to be an alternative payment model. Really different outcomes. The state is open, I think, to the provider's suggestion that basically head count is an easier, more administrable way to count. But that's just the state reps who were in the room. They would have to actually convince their fellow colleagues and ultimately get the feds to agree. So that was never really clearly defined in the commitment that the state made, so it's an open question.
Because that seems really super critical to designing any kind of approach that's
totally
going to work.
Yes.
I had a question. You had mentioned when you were envisioning the full upside downside risk, you said, X-ray, all these different things would likely be included, but not behavioral, probably not behavioral health. Why did you say probably
Because
not behavioral health?
the community mental health centers already have an alternative payment model with Medicaid, and what the hospitals and physician practices at least have been advocating is, why would we disrupt that? It took over a year, I think, for the CMHCs to actually negotiate that deal. We need to give it time to see if it works, and why would we expend additional resources layering on something that may actually work for that patient population? And so it's not that it couldn't include it, it's just that, at least from a Medicaid perspective, that's my personal bent, is that I think we should acknowledge the great work that the CMHCs and Medicaid and the MCOs have already done, and give us some time to actually work.
But it should count towards it.
Pardon me?
But it should count towards it.
Yes.
Towards that 50%.
Yeah, oh, definitely, yes. Sally?
Lynn, we heard from Andrew at DHHS, the data person, that there was a 40% turnover from year to year in the Medicaid population. So you're thinking about an APM with a 40% turnover in the denominator. How does that influence what you're thinking?
That's an excellent, so for those of you who didn't hear the question, so some of the state statisticians have done some data analysis and have determined that, as many of you in the room know, the Medicaid population turnover or churn is significant. So at least 40% of Medicaid recipients go in and out of Medicaid coverage in any one given year. And so what we've said to the state is, you gotta keep that in mind, because it's not like a Medicare population or even a commercial population where it's those other populations are much more stable. Medicare, take it for example. Once you are a Medicare beneficiary, you have two choices, right? If you opt into Medicare, you're either an original Medicare, or maybe you pick a Medicare Advantage plan. But you're in for the full year. Once you made the decision on which plan, you don't think about it, right? And a commercial payer, same deal. Generally, if you're covered through your employer and you're there at the same employer for the full year, you're in for 12 months. So if you think about quality measures, right? If we think about even HEDIS measures, which are generally used in the commercial market as a way to standardize measurement, it's all based on a 12-month stable enrollment. If you think about severity of risk, right? What's the risk, chronic risk profile, chronic burden, or illness burden of a particular patient population? The 3M model, the hierarchical care condition model, all of those risk adjustment models are based on a 10 to 12 month full enrollment period. Medicaid doesn't work that way, and it's not because the Medicaid beneficiaries don't want to necessarily be in for 12 months, it's just the way the program is designed. And so we've asked the state to acknowledge and think about, as we collectively develop these models, what we do for that. Because it has to be, and which may mean you can never get to full downside risk or full capitation, because it's not actuarially sound. But it is a challenge. Yep.
Could you say a few words about the roadmap and how much of an implementation plan it is, how prescriptive it is?
About the what?
The roadmap.
Oh, so the timing right now seems hardwired. I don't know that the feds are willing, even if the state asked, to extend, right? Because part of the issue is the district grant's a 5-year grant. And the idea is to have the payment models moved prior to the end of 2021 when the grant ends, and that these should be sustainable models, which the providers, the MCOs, whoever, will by then have figured out, theoretically, how to make them sustainable once the grant money goes away. So from that perspective, I think we have to think of that as a hard date. The procurement process could move slightly, but I don't know if anyone's from the MCOs have any greater insight, but the idea is to have new new contracts in place with whoever, whether it's the 2 incumbent MCOs and or any additional MCOs in place by July of 19. So the idea is that this spring sometime soon, the bids will go out, the request for proposals will go out publicly, and anyone and everyone who's a managed care organization, not just the 2 that we have, can actually submit a bid. And then the state will evaluate those bids, go through a process, go through a negotiation process, and ultimately, according to the timeline, by January of 19, we would know who the MCOs will be in our state for July of 19. In the meantime, during that negotiation process with the MCOs, the state will also be focused on, in the RFP, the request for proposals, they will be asking the MCOs to tell them how they envision they're going to help the state achieve that 2020 goal. In the back?
You choose that 50% population being a new model, and we're delivering Medicaid long-term care services. How are we involved?
Good question. So the question was, for Medicaid in the 2020 and the 50%, how are long-term care providers involved? There have been representatives from the long-term care and developmentally disabled organizations. It's unclear really how, from my perspective, how that will those type of services will be included or not included, because they've been part of the phase 2, and really not a lot of public attention has been paid about how those might be impacted.
We're currently in phase 1.
Right. Yeah. So, good question, I don't know.
Other states about what they've done?
Pardon me?
Could we look to other states for what they've done?
Yeah, so there have been other states who have tried to do this. So Arkansas has done a little bit of it. New York has a DSRIP grant. There are other, Indiana I think has done something. The problem is that, as many of you know, New Hampshire likes to be different, right? Unique, distinctive, whatever we want to say. And so the ability to just take someone else's model and say, yep, this is how it's going to work, is probably not possible. We can take bits and pieces, but I don't think there's one model that we could replicate that would actually be the New Hampshire way. Alrighty, well, thank you. Oh, Eileen?
So do the community mental health centers, that contract is for all of you?
Yes.
So you didn't each independently have to contract?
Well-
It's the same contract, same requirements?
Same language, not the same rates.
Oh.
And some of the folks have been in and out of the general contracting, but we have a person that does the contracting from the association, who does the contracting mostly of the language. And then the centers do not have the same rates. It's based on utilization. So they're all we don't know what they are. We can't share what those rates are. We know our rates. That's what we agreed to. We don't know what everybody else's rates are.
Right, so you have a base contract,
Correct, the
and then
language.
10 different CMHC rate
Same format.
schedules,
structure.
right.
And I would just add to this that we would say that alternative payment model has worked. And it's been way
Right.
better than fee for service, and it saved it saved my organization, saved the day basically. You know, it's a different approach. It's not perfect,
Right.
but we were very glad that both MCO companies would want to engage in something new and creative because it's been very, very helpful.
Yes.
And I think, so Dartmouth-Hitchcock has several alternative payment models. We actually think these models can work. It's just, it requires attention to detail, trust on both sides, right? Because this is a negotiation and we both have to trust that we are sharing data, we're understanding what the intended and unintended consequences of these arrangements might be, and if things aren't going well, we need to be able to go back to the table and have a conversation about how we move it forward so all sides are continuing to actually feel positive about these type of models. Eileen?
So who is the we that has to negotiate these contracts? So
Uh,
when I think about, so we're Region 1 and we have a number of organizations that bill Medicaid for services. Do each one of those organizations need to be involved in negotiating this APM, or is this done at a region IDN level? If it's done that, why not then at a statewide level?
So here's what I'm personally advocating for, and others can disagree with me. I don't think the IDNs are the place to actually do the negotiations. IDNs, Region 1, the IDN doesn't actually technically exist. We're not a corporate entity. We don't have any balance sheet. We don't have Mary Hitchcock Memorial Hospital is actually the fiscal agent for Region 1. Other regions, I think, may also be sort of loose coalitions and not necessarily an actual entity with a tax ID number and employees and all that jazz, right? So I personally think that the IDNs can be the sort of the way that we collaborate and we bring the regions network together. But I think ultimately it's going to be provider organizations who are taking the financial risk, who are managing it, and then we're using the IDN as ways to foster collaboration, improvement, that kind of stuff. Others could disagree, but that's my personal opinion. Sue Ellen?
And just from personal experience, and I don't know how you feel about this, but you need to hire somebody to do that for you.
Yes.
So any of these small entities that may be out there, and we're not even that small, there's a skill set that goes with that the everyday person doesn't have.
Correct.
So if you get to the point where you need to negotiate rates and language,
right,
you need to think about somebody that has a skill set and not take it on yourself.
Right.
So is that the role of the IDN, is to be
It could be.
a educator and a facilitator to bring those entities together to say?
It could be, yep.
Yeah.
Because I agree. I think that that's asking a lot for many of our organizations who already, are challenged with staffing for, never mind direct patient or client care, and all the other stuff that needs to go along with keeping the places running, and then being able to, in our challenged workforce environment, then also have at each organization someone who knows how to negotiate contracts, who can do all those things, who has the ability to help manage the financial risk. That's not an investment each organization probably can or should be making. Sally?
So Lynn, I agree with you. I think this is not an IDN problem. This is a state problem. But I do wonder if this is a time for us to think beyond the ACO and think about the AHC, the Accountable Health Community. For this population in particular, you've got 40% turnover in the denominator. This is a population that is so impacted. We already know by definition they're financially challenged, and the social determinants of health probably in this population more than any other single population that I can think of they're so critical. Where we've underinvested in the social determinants of health can we think, and I don't know if any other communities have done this or states have done this, think about creatively how to engage these partners as part of that model that's going to benefit?
Yeah, so Sally's question was, as we think about beyond just accountable care organizations and we really think about accountable care communities, right? And how we could more ensure that we have the ability to invest in resources to also address social determinants of health, which everyone I think appreciates at this stage actually impacts the health of the individuals that we're all treating or caring for. I think the state of Vermont is actually a potential. So One Care Vermont ACO, which is co-founded by Dartmouth Hitchcock University Medical Center of Vermont, has a accountable care global budget model with the Vermont Medicaid office as of 1/1/18. And so the ACO has worked with many of the hospitals, provider organizations, community mental health centers in the state to develop these networks. And they are trying to, One Care Vermont is trying to pull together the community organizations, so the social service agencies that I, wearing my Dartmouth Hitchcock finance regular hat, don't talk about, right? I don't engage with, but are critical to the care within our community. And so how does WISE fit in, or other organizations that are doing really good stuff. Like, we have Headrest here, but other organizations, and so they're trying to convene groups within each community in Vermont to focus on how do we do that. And there's some small dollars available to participants in those networks to help fund some of that work. And so I think in New Hampshire, we don't have that same mechanism right now, but we may want to think about, is that something we could replicate? All right, thank you.